Welcome to our little micro tutorial with the CMH Family Medicine team. I'm Dr. Madeleine Muller. Thank you to Dr. Ashraf Mohammed that's helped us with these slides. And we are busy focusing on two things, deep vein thrombosis and pulmonary embolism. And in this particular section, I'm going to focus just on deep vein thrombosis and how one actually makes a diagnosis. So we've talked earlier about patients that you might be suspicious in, but what would actually make you think that this is a DVT on your clinical picture? And the classic triad that we look for, the most common one is actually usually a unilateral leg swelling. And you can see there it's got a 97% sensitivity. So if a leg's not swollen, it's probably not a DVT. You need to have a swollen leg to have a DVT. Pain also very common. 86% of people with a DVT will also have pain, and 72% of them, that leg will actually feel slightly warmer. So most patients with DVT has that lovely combination, swollen leg, pain, and warmth, but there are lots of people with swollen legs that do not necessarily have a DVT. So you can see the specificity there is very low. So what do we want to think about in our differential diagnosis? Well, the first thing is this might be an infection. And cellulite is probably the one that can be the most tricky. So they might also have a hot, painful cough. Helpful if they have a fever. You usually won't get a fever with a deep vein thrombosis. And you might find that some of the areas has got warmth in it. So not all of the areas, but sort of patches on the leg itself. One can also get superficial thrombophlebitis, that's here at the bottom, and you can actually sometimes even see or feel those palpable, tender, superficial veins in those scenarios. The other thing is it might be a circulation issue, such as lymphedema or chronic venous insufficiency, varicose veins, but usually in those scenarios, you would see bilateral swelling of the legs. So the unilateral is certainly a helpful clue. The other thing that can be very confusing is whether it's caused by either the muscles or the bones. And a classic one is the so-called ruptured popliteal Baker cyst. So you can see here behind the knee, one can actually get a little, you just get my pointer, you can get a collection of fluid called a Baker cyst. And if that Baker cyst pops, you can see that can cause a very hot, swollen red area that might make you think of, could this possibly be a DVT? The other thing might actually be a pull or a tear in that calf muscle. So for example, somebody wasn't warmed up and then they make the bed and lean forward and pull a calf muscle. And it could also be due to, for example, an inflammation or swelling of the knee. So what's going to help us? And what's very helpful is there are something called the modified Wells probability score. It gives you sort of a likely versus unlikely conclusion, which is very helpful. In the old days, we used to use things like the Hohmann sign to diagnose, but this is actually very unreliable. So just forget about the Hohmanns. And we're going to basically just use this scoring system to help us figure out whether we need to send that patient for an ultrasound to look for DVT. So you can see there our cutoff points has to do with 2. So if they've got a score of 2 equal to 2 or more, then that's likely to be a DVT. If they've got a score of less than 2 points, that's unlikely to be DVT, and we'll run through those algorithms in a minute. So let's just look at the kind of things that's going to give us points. So somebody who's got active cancer or has had treatment within the last 6 months, somebody who's immobilized, for example, due to paralysis or a plaster cast of the lower limbs after a fracture, somebody who's bedridden for whatever reason for more than 3 days, or who has had major surgery in the past 12 weeks, anybody who's actually got vein tenderness as you feel along that venous distribution. Leg swelling, as we've noticed, very important. And what's helpful is to understand where you measure that leg swelling. So we've got a little picture up here where you can see 10 centimeters under the tuberosities of the knee is where you do your measurement, and you compare with the opposite side. And if that sort of circumference of that calf is more than 3 centimeters on the opposite side, then that will be considered a swollen leg, and you'll get 1 point for that. Any collateral veins, so non-varicose superficial veins that the patient has, other superficial veins that are also distended. Very important if there's a previous history of DVT. And then if there's an alternative diagnosis, so say you examine this patient and it definitely looks like they've tore a muscle or looks like a Baker cyst, then you would subtract 2 points from this scoring system. So now that's going to give you a nice number, and what do we do with that number? Before we move on to the algorithm for the number, just a quick word about D-dimers. So everybody gets excited about using D-dimers to diagnose, but actually D-dimers are only useful to exclude a DVT. And you can see in the right top-hand corner here, I'm not going to bother to go through it. There are a vast number of things that can give you an increased D-dimer. So it's not going to help you to tell you whether this might be a DVT. The only thing it's helpful for is if you want to just completely exclude the fact that it's a DVT. So if a D-dimer is negative, then you can rest assured the patient is fine. What's important to realize is that the older you get, this D-dimer cutoff changes. So if you're under 50 years old, then we use less than 500 micrograms. But if you're more than 50 years old, then you're going to times the age with 10. So for example, if you've got a 75-year-old patient, you times it by 10, so then your D-dimer cutoff will be less than 750, and that just helps that we don't end up having too many false positives. So let's just go through the algorithm. So if your DVT score is under 2, so it's either 0 or 1, in those scenarios, we can still then do the D-dimer to help reassure us that we've definitely made a good clinical diagnosis, and if the D-dimer is negative, as we've said, you're going to exclude the DVT. If your D-dimer is now positive, remember I said there's a whole list of other things, but what we want to do is that you want to organize an ultrasound, but your ultrasound is not quite so rushed. So they can say, as long as you make sure you get an ultrasound within 3 days, and you wouldn't start anticoagulation, because remember that initial score was very low. But what do you do if the score is either 2 or more? And in those cases, it's important to get an ultrasound. And the recommendation is you actually want to confirm that diagnosis within 4 hours. Sometimes it takes longer than 4 hours. So whatever in those scenarios, you certainly want to start anticoagulation even while you are waiting to get that ultrasound organized. If the ultrasound confirms DVT, we'll talk in another tutorial about the management. If the ultrasound is negative, because of that score, we're going to then do a D-dimer just to reassure us. And if the D-dimer is then negative, excellent, excludes DVT and we can relax. If the ultrasound was negative, but your D-dimer is positive, then a week later, we would repeat an ultrasound and just make sure that there's not something that we missed that might have been an early on development of something. In our setting now, ultrasound is actually becoming more and more accessible because you can do a point of care ultrasound. So even within a district hospital facility, a doctor can use, for example, the obstetric ultrasound machine to do a very quick check for a DVT in a CHC setting, even possibly, or in a district hospital setting. So the thing with POCUS, so point of care ultrasound, is it's useful if you can confirm the DVT. So if you find it, excellent, brilliant, and you can treat. But if you're quite inexperienced and you haven't done a lot of these, you probably can't use it to exclude a DVT. So if you can't find anything, but the person has scored more than 2, you're going to have to get them to a hospital for that ultrasound. And the principle is simple. If you're lucky, you might actually see the thrombus. This is a picture of where you see the thrombus. But in most cases, you need to only be able to identify where the artery is. This is a cross-section through that artery, where the vein is. And then you're going to see if you're able to compress that vein. So if there are no blockages in that vein, the vein will be able to flatten quite nicely when you press on it. So this is a skill that's quite easy to learn. All you need to learn is where to put your probes. And there are lots of lovely courses that will show you, depending on which level that you're putting your probe at. You can see here's an example. They will show you what you expect to find on the ultrasound, where your artery is going to sit and where your vein is going to sit. And then all you're going to do in each of these levels is to check whether that vein is compressible. So one of my big encouragements with this little tutorial is to see if you can get to pick up at least this very basic skill to assist you in your facility. Great. So now we've talked about deep vein thrombosis. In our next tutorial, we're going to be focusing much more specifically on the pulmonary embolism and looking at how we again use something like the wells to diagnose that. Thank you very much.